All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the VOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once this statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. Our speaker this evening is Dr. Miho Tanaka. She is a sports medicine surgeon recognized for her research in patellofemoral disorders and gender-based differences in orthopedic injuries. She joined the Massachusetts General Hospital Sports Medicine Center in July of 2019. Prior to her arrival, she was an associate professor of orthopedic surgery and the founding director of the Women's Sports Medicine program at the Johns Hopkins Hospital. Dr. Tanaka completed her undergraduate degree at Stanford University, where she was a member of the varsity track and field team. She earned her medical degree at New York Medical College, and she completed her orthopedic surgery residency at the Johns Hopkins Hospital in Baltimore. After residency, she completed a fellowship in sports medicine and shoulder surgery at the Hospital for Special Surgery in New York City. She has served as a team physician for multiple professional, semi-professional, and collegiate sports teams, including the St. Louis Cardinals, St. Louis Surge, Johns Hopkins University, and the U.S. Soccer Federation. She has also published or presented over 80 articles and book chapters with a primary interest in the anatomy and biomechanics of the knee. She serves as chair of multimedia for the American Academy of Orthopedic Surgeons and is a member of the Education Committee for the Arthroscopy Association of North America. She additionally serves on the Electronic Media Editorial Board of the American Journal of Sports Medicine, on the editorial board for the Arthroscopy Journal, and on the Associate CME Editor Panel for the Journal of Bone and Joint Surgery. She is presenting on evaluation and management of patellofemoral disorders.
Thank you so much, Michelle. Let me see if I can get these slides pulled up here. So does this look okay from your end?
All right, right now we have a white screen.
Ah, that's strange. Okay, let me X out of this and try again.
See the slides currently.
Ah, that's so strange. Let me, I'm gonna stop this and I'm gonna restart my PowerPoint. I've had this issue once before after a test run. So let me try this. And sorry about that. Okay. 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 So how is it now? It looks like it's paused.
Now it's frozen. Oh. Okay, and we are back to that white screen.
Huh. It worked earlier, just a few minutes ago when we were testing this. I'm so sorry. Let's see. Let me see what else I can do. How about?
Oh, and now we've got it.
Oh, you've got it.
Yes.
Oh,
Maybe it was like a first slide. Yep. Oh, and we are seeing all your slides.
now you're seeing all my slides. Okay, let me
Yes.
get back to this. How's that?
Beautiful.
Okay, should I get started?
Absolutely.
Fantastic. Sorry about that. Let me just get rid of this thing here and see if I can get rid of all these windows so I can see my screen. All right, guys, sorry about that. Thank you so much for the opportunity to give this talk today. And thank you, Michelle, for that nice introduction. I'm going to be talking about the evaluation and management of patellofemoral disorders. These are my disclosures. So when we talk about patellofemoral disorders, this is generally considered to be a spectrum. So on one end, we have instability with patellar dislocations, and on the other end, we think about patellofemoral pain. And somewhere in between, we have something called maltracking, and we'll talk about all three of these items today. So when it comes to patellar instability, we know that this can be traumatic or atraumatic, and the stability of the patella typically depends on the ligamentous restraints, which hold it in place, the dynamic muscular forces, and the bony anatomy. And disruption of any combination of these three components can lead to patellar instability. This has the most common onset during adolescence, generally between the ages of 10 and 17 years old, with the highest risk in female adolescents with a rate of 5 to 29 per 100,000. This is most common in sports such as football, basketball, and soccer, and a 9% incidence of a positive family history is noted. We know that the most likely risk is in patients who have had a prior dislocation, so this constitutes 49% of patients who present generally for evaluation. Now, when we talk about the anatomy of the patellofemoral joint, on the patella, we know that this is a sesamoid bone. So this means that it's a bone that's embedded within the tendon, going from the quadriceps tendon and extending down into the tibia through the patellar tendon. And it serves as a fulcrum for the quadriceps muscle in extending the knee. On the other side, we have the trochlea, which is part of the distal femur, and this is where the groove is, where it sits. Now, underneath the patella is the cartilage undersurface, and so it's always important to remember that this is a joint, and the joint is fairly complicated. When we talk about instability, there are multiple words that we use. So subluxation has to do with transient lateral movement of the patella, which can lead to instability or pain. We have maltracking, which means abnormal tracking of the patella throughout range of motion. So it's not just about what happens at a specific point, is the patella going left or right, but it's also what happens to the patella throughout knee range of motion, which is what makes it so complicated. And then lastly, the term laxity. So this refers to a loose patellofemoral joint, which may lead to abnormal translation, but that doesn't necessarily mean that it's symptomatic or that somebody might have functional limitation from that. So important to differentiate between those three. Now, the mechanism of a patellofemoral dislocation without trauma typically happens as shown in this picture. External rotation of the tibia with a valgus force and slight flexion. This typically happens when a player kind of plants with their foot externally rotated and they go to pivot or push off and their kneecap pops out. And what we know is that in these patients who have an atraumatic patellar dislocation, the majority of them have some sort of predisposing factors. So what are the predisposing factors that exist for patellar dislocators? So we'll go through these. The first is trochlear dysplasia. The second is Patella Alta. The third is involves rotational and angular bony malalignment. And we'll talk about all of these in the subsequent slides. And ligamentous laxity is an important component as well. So when we talk about trochlear dysplasia, this refers to the shape of the trochlea, and the trochlea is the groove where the patella sits. So on the left, you see a picture of a normal trochlea. You can see that the groove is fairly deep, and this trochlea is what provides the bony constraint when the knee is flexed to about 30 degrees and greater. Now on the right, you see a picture of a dysplastic trochlea. So this is an abnormally shaped trochlea, and you can see that it's pretty flat. And there's really no groove, and you can imagine the patella wanting to just slide off the edge of that. And what we know is that in the majority of knees, about 96% of patients with patellar instability, they have some degree of trochlear dysplasia. Now, We talked about how this is a flattened groove. It is also tends to be bilateral, so patients tend to have this on both sides. And it is also tends to be associated with other types of deformities and malformations in the knee. I think it's also important to talk about when we say it's a flat trochlea, it doesn't necessarily mean that one side or one wall is too low. And it doesn't necessarily mean that the groove is too flat. As you can see here, this is a computational summary, if you will, of patients, of my patients who have patellar instability. And then the gray is a combination of patients averaged together who don't have patellar instability. And the mesh, you can see the difference between normal and versus abnormal trochlea. And you can see here, I don't know if you can see my mouse on this, but in the middle where the groove is, you can see that the groove is elevated, making it flat. But on the lateral side, so to your left, you can see that the mesh is actually lower. So the walls are lower. So this is a lot more complicated than just a flat groove. Now, in terms of Patella Alta, this refers to the height of the patella. And this is associated, another risk factor associated with patellar dislocation. And these patients are more likely to have a dislocation without trauma. Now, why is this? If you have a patella that is higher up, okay, then as you bend your knee to 30 degrees, your patella doesn't actually engage in the trochlea. So you have a larger window of opportunity where you only have the soft tissue restraint, which makes you more likely to have a dislocation. Bony malalignment, when we talk about this, refers to several things. So if you look at this picture on the right, you can see that this girl's toes are pointing straight forward and her kneecaps are pointing right at each other. Okay, so this is something sometimes we call a squinting patella. They're facing each other. And this can happen as a combination of factors, femoral aneversion, coming from the hips, genu valgum, where you could be knock-kneed, which in this case the patient is not. External tibial torsion, meaning that the tibia and the shins are externally rotated relative to the knees. But all of these things lead to the same problem, which is a lateralizing force on the extensor mechanism. And the extensor mechanism is the quad patellar tendon, as we talked about previously. And so what happens when you have this lateralizing force is that when the quadriceps contracts, this mechanism seeks the shortest route between origin and insertion. So if you look at this picture, as the quadriceps contracts and it's not going in a straight line, it'll put a valgus or a lateralizing vector on the patella. And so this is why this is a risk factor for that. Lastly, the dynamic restraint, when we look at this, so here you can see the quadriceps muscle, and I'm sure everybody's familiar with that. With the quadriceps muscle, it's 4 muscles in one. 3 of them are on the lateral side, and 1 of them is on the medial side. So so the VMO, which is the medial muscle, is the main one that provides a stabilizing force to the patella. In terms of soft tissue restraints, in addition to the dynamic restraints, we have ligamentous restraints, which we call the static restraints. And I'm sure most people are familiar with the term MPFL, medial patellofemoral ligament, which is known to serve as the primary restraint against lateral translation of the patella, primarily from 0 to 30 degrees of knee flexion, because after that, it engages within the trochlea, as we saw earlier. Now, there is some recent change in the terminology, and we'll talk about this in the next few slides. But overall, even though the name has changed, we kind of know that the function of this has low tension throughout flexion and extension, and it remains isometric, so from 0 to 90 degrees. Now, this is a pretty puny ligament, as you can see in this picture here, and it can withstand only about 200 newtons of force before it tears. This is in comparison to, for example, an Axial, which can withstand almost 2,000 newtons of force. So if you look at this and you see in the last picture also, instead of MPFL, we saw the title, or we saw the terminology MPFC. So this is an articular sided view from one of my dissections looking at the inside of the knee. So this is the knee looking from the inside out. Okay, so we're looking up or into the front of the patella. We see the undersurface of the quadriceps tendon with the undersurface of the VMO. And labeled right here is the MPFC, formerly known as the MPFL. And you can see that this attachment actually not only goes to the patella, but also goes to the quadriceps tendon. And so the name of this has evolved over the last 5 years or so. And now we call this the medial patellofemoral complex instead of the patellofemoral ligament, to allow for the variability in the anatomic attachment site. So this is a term that you may continue to hear going forward. This is from a study that I did in 2016, and several others have shown similar things. Again, a very similar view with a dissection. And in this, I showed that the attachment site varies. So some people will say the MPFL attaches to the patella, and there's another ligament, the MQTFL, attaching to the quadriceps tendon. That's what the QT is. But it actually looks like it's one ligament, and that it can vary between individuals. Some attach to the patella, some attach to the quadriceps tendon. Most people attach about 50-50 to both. So again, this is where the term MPFC comes from. In general, we think about this as the proximal restraints, which is the MPFC, also known as the MPFL and MQTFL. I know this becomes like alphabet soup. And then the distal restraints, which include the MPML, attaching to the meniscus, and that to the tibia. Now, I won't get too much into detail into the distal restraints, but that kind of gives you a little bit of background on that. Now, when these patients present after patellar dislocation, you can have an acute and fixed dislocation, meaning they come in, the patella is still out. That is pretty uncommon to see, but if they are, they usually are holding their knees in a flexed position. And when the kneecap is out, they'll see the empty trochlea and the femoral condyle, which looks a lot more prominent when the kneecap is not in its groove. And so a lot of times these patients will tell you that they had their patella went medially because they see this large bump there, but that's typically not the case. Medial dislocations are pretty uncommon, not impossible, but it's important to know that you may hear that sometimes, and you have to know really what to look for. Now, the patella typically reduces in most cases, but if it's not reduced and they come in with the knee flexed, you can gradually extend the knee and sometimes put even a little bit of medially directed pressure on the patella. You don't want to slap it back in, you don't want to slam it back in. This is something that wants to go back into place, especially when the knee is extended. The difficulty with patellar instability, and especially in evaluating it, is that the patella can move all over the place, right? So it's not just about, is it going lateral or medial? We know that it can rotate in either direction. We know that it can tilt in either direction. And not only with medial lateral tilt, you can have proximal and distal tilt as well. So there are multiple degrees of motion that we have to consider when assessing the patella. Typically, when we think about the clinical examination, we want to make sure that they're able to ambulate. We want to address and document the extent of their effusion, whether they have any bruising, whether they have what kind of range of motion. And this is kind of standard for any sort of acute injury with the knee, as well as a thorough ligamentous examination, because a lot of times, unless they show up like this picture, it's not always easy to tell the difference between a patellar dislocation or an ACL tear, because the knee is swollen. Typically they have, a pivot, they felt a pop, and they come in with a knee that's very swollen and difficulty walking. So then it becomes very important to be able to evaluate the knee and to examine the patella. And one of the primary ways that we do this is called the glide test. So with the glide test, you're pushing the patella medially and laterally, and then quantifying the amount of movement based on patellar quadrants, with 2 quadrants being half of the width of the patella. The standard or the normal amount of motion is about 2 quadrants medially and 2 quadrants laterally. I do think it's helpful to compare this to the contralateral side if it's non-injured, to get a good sense of what's normal for that patient, because not everybody has the same amount of 2 quadrants medially and laterally. The apprehension test is not just about motion, but talking about symptoms. So this is something that's performed at about 20 to 30 degrees of knee flexion. And if you try to push the patella laterally or medially, and the patient tries to stop you because they feel like their kneecap is going to pop out, this is a positive test. So earlier we talked about laxity being just increased motion, not necessarily increased symptoms, but the apprehension test helps to determine if they have symptoms from this. Now, I did say in both of these prior tests that you have to check laterally and medially, and that's because medial patellar instability is a real thing. And I would say this is one of the most missed diagnoses that I see, very, very uncommon. However, if somebody has had a previous lateral release, which we used to do all the time for these patients, then you should have a high suspicion that they may have a problem where the patella is going laterally, especially if they tell you that their patella is dislocating and you can't get it to go laterally. You also need to check medially as well. This is not something that's going to show up on imaging, okay? So you have to, especially with patellofemoral disorders, this is primarily a clinical diagnosis. And in the case of medial translation, this has to do with increased medial translation. So you can see here in this picture, I can get my thumbs right into the trochlear groove in this patient. And apprehension, meaning that moving the patella medially, they feel apprehensive. It is important to differentiate between apprehension, feeling like it's going to pop out, versus pain, which is much more common. The patellar tilt test looks for lateral retinacular tightness, and you can see here an example of this. Generally, the patella should get to horizontal, and in some cases, if it's very, very tight, it can't get there. Again, I think it's important to look for symmetry in these cases. Pain with patellar loading. So this is kind of the pathognomonic sign of patellofemoral pain. If you load the patella during active quadriceps contraction and they have pain, this means that they have some inflammation in the knee, and this is consistent with having patellofemoral pain. Now, this can be done either with the patient's legs hanging off of the edge of the table and you have them actively extend their quad while you push on their patella. The other way to do it is to have them just, laying there and to contract their quad and to push on the patella. Be careful doing this because it's actually a pretty painful thing. And so you don't want to surprise the patient by doing that. Always important to look at alignment. So we talked about this earlier. Here again is an example of this, what we call the miserable malalignment. The hips causing the femur to rotate in, sometimes a little bit of knock-kneed kind of configuration, and then external tibial torsion. So, normally you think about the knee and the extensor mechanism, which was what we talked about, and that goes kind of in a straight line. So it's quadriceps, quad tendon, patella, patellar tendon, and down into the shin, and it should closely approximate the front of the knee. But you can see that on this patient, it's very angled, and we talked about why this is a risk factor, and identifying these risk factors and documenting them is important during the examination. Pes planus, so being flat-footed, can also accentuate this, so it's important to consider the entire lower extremity. One way to measure this and quantify this is the Q angle, which I'm sure that many of you are familiar with. This is measured as a line going from the patella to the anterior superior iliac spine up on the hip, and then from the patella to another line with the patella to the tibial tuberosity, with normal values being 14 in men, 17 in women, abnormal considered greater than 20. This has been noted to have abnormal values in more than half of patients who have recurrent instability. There's multiple ways to measure this, so the numbers aren't always necessarily consistent, but it is one way to document this. Now, the J sign is the other thing. So we talked about maltracking and watching what happens to the patella during range of motion. So here's a video. The J sign is where you have the patient extend their knees slowly, and you can see what happened to her left knee. Pretty pronounced there. Looking at the J sign, we have actually found that if you can somehow measure the extent of lateralization of the patella during this motion, it can actually predict whether they have instability or not. Because again, having instability where the kneecap pops out is very different from having patellofemoral pain. And so we want to be able to differentiate between the two. So the J sign is one way that we can do that. VMO atrophy. So earlier we talked about the dynamic restraints, which are the muscular restraints. We talked about how a lot of these patients, if you have VMO atrophy, then that means you only have one muscle, right? We talked about if you only have one muscle on the medial side and 3 on the lateral side, and that one on the medial side is not working very well, then that can effectively increase the lateral pull of the quadriceps mechanism on the patella. So strengthening the VMO tends to balance this, okay, and increase that medializing force. And this is why physical therapy works, actually. This is one thing that if we find it on examination, it's one thing that can actually be addressed. And then generalized laxity. So we know that ligamentous laxity is a risk factor for this. And even if you have an intact ligament that holds the patella in place, if your ligaments are lax, meaning that you're very, very flexible, then that can contribute to this problem, even though you don't necessarily have a tear, for example. One way to quantify this is Baten's criteria. So this means, can you abduct your thumb to your forearm, as you can see in the middle picture, passively hyperextend your little finger, elbow hyperextension, knee hyperextension, and then trunk flexion. And so the first 4 are graded bilaterally for a total of 9 points. X-rays at the time of evaluation. So hopefully you'll never see an X-ray that looks like this. In most cases, the patella will be reduced before you send a patient for X-ray. There's a lot of things that you can actually learn from the X-ray. And one of the things that I hear so commonly from athletic trainers and patients is, why would you get an X-ray? I didn't break anything. But there are a lot of things that we look for that can give us a clue as to what is going on and what your risk factors might be. So on the lateral X-ray, we can look at the height of the patella. We talked about Patella Alta being a risk factor. Patella Baja means the patella is low. That's less common with this type of problem. Trochlear Dysplasia, the main classification system for trochlear dysplasia, is actually described on the lateral X-ray. So these things are helpful. One way to measure Patella Alta, because I think this is really important, is the Caton-Deschamps index. So previously, if you asked 20 years ago, we talked about Insel Savati or the modified Insel Savati. Now I think the most popular measurement is the Caton-Deschamps index. This is measured as, in this picture, the blue line over the red line. So the distance from the patella to the tibia, and then that divided by the length of the articular surface, the Patella Alta being diagnosed with an index of 1.2 or greater. Axial imaging is important too. So it's not just about, any X-rays, but it's what type of X-rays are you getting specifically. Now you can see that with the axial images, you get a nice view of the trochlea. You can see trochlear dysplasia with this. And in some cases, even patients tend to have a little bit of an avulsion fracture from a patellar dislocation that you can't see unless you get this view. So X-rays are very important. Now CT is another type of test that you can get. It's good for showing you the patellar position, trochlea anatomy, and measuring TTTG distance. Now that is a measurement, as you can see here, that generally reflects the sort of, again, the Q angle or the lateralizing malalignment that we see, that lateralizing force on the extensor mechanism. And it's basically the distance from the center of the trochlear groove to the tibial tuberosity in terms of medial lateral distance. So this picture shows a cross-section of the trochlea, a cross-section of the tibial tuberosity, the 2 points that you can see on the picture on the right, and then measures that distance. And the higher the number, the greater the lateralizing force. Typically, greater than 20 is considered to be abnormal. Now, you can measure this on an MRI, but it has been shown to underestimate this. It's also important to know that depending on the position of the knee, the TTTG distance can change. So again, it's not just a hard and fast rule in terms of what the number is. How it's measured, or even the patient's size, can influence this, and that's important to go by as well. Dynamic imaging, or 4D CT imaging. We talk about 3D imaging. 4D adds on the element of time. This is something that I had the good fortune of working with in my prior institution when I was at Hopkins. We have the patients, positioned sitting, as you can see here, and then they actively extend the knees over 10 seconds, and the images are acquired every half second to give you a good sense of, let me see here. What's happening with the knee. So one of the problems with the J sign is that it's really hard to see where the patella is going relative to the groove in these patients, especially if they tend to be a little bit bigger, but even if they're not, you just can't see past the skin and see the groove. And so we have been able to apply this sort of 4D imaging and then map out the path of the patella relative to the trochlea. So 50% bisect offset means it's perfectly centered, with 50% of the patella being lateral to the trochlear groove. And you can see that in this patient, they get up to 125%. So that means the entire trochlea is past the midline of the patella. I'm sorry, past the past the midline of the trochlea. Sorry about that. Moving on to MRI. This is a more commonly used imaging method for this, but again, we talked about the value of measuring TTTG on CT. Now, the MRI can show you soft tissue as well, so this is important. It can show you an MPFL tear. The most common things that you see once a patella dislocates is a tear of the MPFL, which happens by definition. Okay, you can't really have a dislocation without having some sort of injury to the MPFL or MPFC. And most commonly, it'll show a chondral fracture of the lateral femoral condyle and a chondral fracture of the medial patella. So you can see where these arrows are. And it may seem a little bit backwards to you, but the reason is that this tends to be a relocation injury. So the patella goes out, hits the side of the femur, and then comes back in, and you can see this bony bruise pattern. Now, MRI is also good because it'll show you any sort of osteochondral injury or any sort of loose body. So, sorry, I don't think my pointer here is working, but this big piece that's off to the right-hand side of the screen is a loose body sitting inside the knee. And so this is important to note because a chondral injury where the piece is broken off, and especially if it's floating around the knee, requires early operative intervention. And so even though we often talk about trying physical therapy or strengthening the VMO, if you have a big chondral injury, this is not going to get better with just rehabbing it, or you may get better, but you're still going to need surgery to address that. So these are the cases where we definitively talk about early operative intervention. Now, not all chondral injuries need to be repaired. Generally, we're talking about greater than 10 millimeters in size, and this can vary. And since we're operating on the knee at that time, it's not uncommon to do a patellar stabilization procedure at the same time. Now, if they don't have either of those problems with the chondral injury or a fracture or a loose body, then a trial of non-operative treatment or a course of non-operative treatment is appropriate for these patients. This typically involves a lateral buttress brace, ice and anti-inflammatories to get the swelling down, activity modification, and then PT and VMO strengthening, which we've talked about already. Now, after a course of conservative management, after a patient has a first-time dislocation, they kind of go into three buckets, and it's about a 1/3 and 1/3 and 1/3. A third become totally normal, okay, and a third continue to have patellar dislocations, and a third are kind of right in between. But the point of this is that not everybody needs surgery after patellar dislocation. And the flip side is not everybody doesn't need surgery. And so it's important to be able to differentiate between these patients. So 30 to 45% of these patients have recurrence. And once it starts to recur, then it means it's going to keep happening. And every time the kneecap pops out, you're doing more and more damage to the undersurface of the patella. And that leads to increased risk of patellofemoral arthritis. So we don't want to keep letting that go. Now, the risk factors for having a higher chance of recurrence: female, Patella Alta, being younger, under the age of 18, having trochlear dysplasia, and having a high TTTG. So these are all things that we've talked about in terms of risk factors. And now we can apply this here into how do we differentiate between the patients who are going to need surgery and who are not likely to need surgery, instead of just saying, hey, you have a 30% chance that this is going to come back and let's just see how you do, right? So this study was written by one of my friends out in Cincinnati, and they had put together basically an algorithm to predict whether a patient was going to redislocate or not. So after a first-time dislocation, if you looked at whether they had open growth plates, whether they had a history of bilateral dislocations, whether they had trochlear dysplasia, and they had Patella Alta, and if you added those risk factors together, and if you had all four of those risk factors, your chances of redislocating with conservative management were almost 90%, okay? So if you know that you're going to do physical therapy and there's 90% chance that you're going to redislocate, then maybe you might want to think about surgery. And so we are getting a little bit closer to what we call risk stratification, being able to kind of predict who might need surgery or not. Certainly not the standard of care to say, hey, you know, you have to have surgery at the first go, but it is a conversation that we do have with some of our patients, and then have them kind of decide, you know, where they feel most comfortable in terms of their treatment. But I would say that the days of saying nobody gets surgery for this problem, those days are long gone. Certainly recurrent instability, those patients need to have that treated. And after a first-time dislocation, you know, if they have a chondral injury or something like that, that needs to be treated sooner rather than later as well. So that's important to know. And then in the middle category, so, you know, we talked about some dislocate, some don't dislocate, and some are kind of in between. So who are these patients? Well, when we talk about recurrent instability, this has specific parameters, right? So if someone says, okay, oh, I did physical therapy and now my patella is still dislocating. So the first is, do they have adequate rehabilitation? Because if you go to physical therapy, but you're just getting ultrasound and not having any VMO strengthening, then that doesn't really count, at least in this case. It counts for a lot of other conditions, but for patellar instability, we know that strengthening is really critical. And then the second is it instability that limits function? So some people just get popping. Some people don't actually have full dislocations or instability. They just feel that their knee is a little weak or something like that. So that's where the physical examination comes in. And it's important to rule out other sources of mechanical symptoms. So what else might be giving a popping sensation without instability in the knee? And so confirming this on the examination with the glide test, apprehension test can be helpful in making that determination. Now, operative treatment is reserved for treating recurrent patellar dislocations. Remember that surgery is to treat instability. It does not treat pain. And the optimal procedure to stabilize the patella is not just a one-size-fits-all. It's tailored to the patient's specific anatomy and type of dislocation. So how do we do this? Well, you have to identify and address the individualized anatomy. Soft tissue deficiencies get treated with soft tissue surgery. Bony malalignment, we talked about tuberosity lateralization and patellar height, those get addressed if they're over a certain threshold. Trochlear dysplasia can be treated with a trochleoplasty. This is pretty uncommon, but we'll talk a little bit about it. And then there's maltracking, and we'll talk a little bit about that as well. When we talk about the soft tissue deficiency, we've already spoken about the MPFL, also known as the MPFC, or combined MPFL and MQTFL. We know it's a primary static restraint. It's injured after patellar dislocation, and we know that reconstructing this can address cases of recurrent instability. And we also know that anatomic reconstruction is critical in avoiding complications. And the complication rate is not low, okay? About 25% can be catastrophic complications such as patella fracture, otherwise things like loss of range of motion, increased pain, and arthrosis. And about half of these have to do with having proper technique. And so this is something that we teach about a lot. And with this, we're looking at where do you put the femoral tunnel. And when this is off, even 5 millimeters of malpositioning of the femoral tunnel can lead to increased patellofemoral contact stresses. And this can be really problematic. So it's important that this procedure is done correctly. Now, it's not always easy to find the correct location. And so now we've moved to using x-ray or fluoroscopy at the time of surgery and using other tips such as looking at graft function during the time of reconstruction. But this is not kind of a simple, again, cookie cutter type of surgery in order to reconstruct the MPFL. And you can have an MPFL reconstruction, but not have it working the right way. One of the most catastrophic problems we see after MPFL reconstruction is a patella fracture. This can be caused by drill holes, which is why some people have moved to a soft tissue only type procedure. We know that we don't want to have double tunnels. We don't want to have large tunnels. We don't want to have tunnels that go all the way across. And the main issue is that if you go through the anterior part of the patella, this is the tension side and can increase your risk for patella fracture. So where should we be putting this graft on the patellar side? So generally we know that it's right at the junction of the quadriceps and the patella, right where the blue line is here. You can either sew it to the quadriceps or you can put a small hole in the patella. And there have been multiple variations of this described. So it used to be just MPFL reconstructions. Now people do MQTFL reconstructions and sew this to the quadriceps tendon. They do double bundles, same as in ACLs, where you put one on the quad and one on the patella. And so far, all of these have been shown to have good results. The problem happens when the MPFL or MQTFL or whatever you want to call it is not done properly. So in addition to not putting the graft in the correct position, over-tensioning the graft can lead to arthrosis. And again, this is very sensitive to these changes. Even 3 millimeters of over-tightening the graft can lead to increased medial patellofemoral pressures and ruin your patellofemoral joint. Moving on to bony malalignment, we've seen this picture before. We talked about lateralization and we talked about Patella Alta. Generally, we talk about malalignment, meaning what is going on with the bone. And so it incorporates both of these things. With lateralization of the tuberosity, we kind of talked about the TTTG distance leading to an increased lateralized force on the extensor mechanism. And if it's greater than 20, we know that this is abnormal. Now, you can correct this by performing a tibial tubercle osteotomy. So that means taking the tubercle and moving it over. And this is a nice way to correct the TTTG distance, or the malalignment as we call it. However, and this is especially important to add this on in these cases where the TTTG is especially high. So why do we have to do this? Well, we know that if you do an MPFL reconstruction only on a patient who has a TTTG greater than 15, then the kinematics of the patella don't actually return to normal. And if you do this on a patient with a TTTG greater than 20, then the graft length and the graft tension changes throughout knee range of motion and can be problematic for that as well. So it's not just about doing one thing every single time, it's about figuring out who's going to need the tuberosity osteotomy. And when you incorporate this, it's a bigger surgery, but I talked about the risks of not doing it, so it's important to consider. We typically do a medializing osteotomy if it's greater than 20 TCTG. You can anteriorize this at the same time if there's some contra lesions, and you can even correct Patella Alta, although this is associated with a few more risks than just the other types of osteotomies, but it is something that you can do to address all of these. So why don't we do this on everyone? Well, there are big complications with this too, with the most problematic one being a tibia fracture, as you can see here. This can happen right after surgery, but can also happen in a delayed fashion when somebody's getting back to running around 5 or 6 months when they have a stress fracture. So these are not minor complications. You can also fracture the shingle, have a vascular injury compartment syndrome, uncommon. And we also showed in our study that there's a DVT rate of about 4%, which is a little bit higher than what we see in ACLs. So it's important to be able to figure out, who's going to need this and who's not going to need it. But when they do need it, it's important to do it correctly. Trochlear dysplasia, we talked about, present in 96% of patients with patellar instability, and we know that this can lead to a bony constraint. Now, that doesn't mean that every flat trochlea has to have a groove created, and there's two ways to do this when we talk about trochleoplasty. You can elevate the wall and make that groove a little bit deeper, or you can actually cut into the groove and make that deeper as well. But the indications for trochleoplasty are still fairly unclear. It's more commonly performed in Europe, and they've had pretty good results, but overall it shows that there is a higher complication rate than we see in the rest of patellofemoral surgeries, and that this can improve stability, but not so great, not always great for pain. Okay, so you can't do this in someone who has open growth plates or arthritis, and generally the thought right now is that it's reserved for cases where stability can't be achieved using other measures. So generally, if you correct the TTTG or correct the Alta and correct the soft tissue issue, then a moderate amount of trochlear dysplasia can be tolerated. So that is kind of the current take on trochleoplasty, but I think this is an evolving process. Now, when it comes to maltracking, this is the last part, and this refers to the abnormal patellar motion during knee range of motion, and we've classified how patellar motion can be seen based on 4D CT. So not just the J sign, but there are other categories as well. But the clinical assessment is still the most important, but continues to be the most difficult. The one thing that people often talk about is if the patella is maltracking, meaning the patella is sitting off to the side throughout range of motion, is this a good time for a lateral release? Because as you know, people talk about this a lot. If you're too tight on the lateral side, just cut it and release it. No, that's a terrible idea. We know that if you release the lateral retinaculum, the lateral retinaculum doesn't just pull the patella laterally, it pulls the patella into the groove, and it has a posteriorizing vector. So if you cut that, the patella actually becomes even more unstable. Not only can it cause medial instability, if you have lateral instability, it can make that worse. Okay, so this is not a known treatment, a currently recommended treatment in isolation for patellar instability. The indications for lateral release are limited. If they've had this in the past, you should raise suspicion of having any sort of medial-sided problems. And again, always important to check for medial instability, even though this is less common, you never want to miss it. The last few minutes of my talk, I'm going to talk about patellofemoral pain. This is probably the other end of the spectrum that I get asked the most questions about, even though, I focus primarily on instability. So what is patellofemoral pain syndrome? Well, first of all, everybody gets it. It's been described in about a third of adults at some point in their lifetime and almost half of adolescents. Okay, so very, very common problem. Patellofemoral pain is pain without instability, and this typically occurs with overloading of the patellofemoral joint. Now, this overload can happen from a variety of factors. Subtle maltracking. You can have a patient who has, a little bit of patella alta or a little bit of lateralization that can just lead to increased stress on the patellofemoral joint. You can have acute trauma where someone falls and lands directly on their knees and kneecaps and doesn't necessarily cause a fracture, but you can have overload again of the joint. Or it can be a chronic overload. So most commonly runner's knee, right? We see this as somebody is kind of starting a new running program or ramping up, and this can lead to repetitive overload. But all of these things lead to pain under the kneecap. After you have pain under the kneecap, this leads to quad inhibition. So I think almost everybody here probably knows about the ACL and quadriceps inhibition. This happens in the knee as a result of patellofemoral pain, and this can alter the load bearing of the patellofemoral joint because the quadriceps is not working properly. And this alteration of the patellofemoral joint can lead to more irritation of the patellofemoral joint, okay? It is important to know though, so some people will say, well, I have a problem with the cartilage. So we call this chondromalacia sometimes. Problem with the cartilage under the kneecap, but it's actually not so much about that. And we know this from a very famous study done in 1998 by Scott Dye, who is a wonderful man, and he let his brother operate on him and scope his knee while he was awake without anesthesia so that he could see what hurts and what doesn't. So this is pretty amazing. And what his study found was that when his brother poked and prodded at the undersurface of his patella, the patella cartilage, there was zero sensation. Okay, so this sort of chondral defect, chondromalacia, the things that we see on the MRI are actually not the source of the problems that we see in patellofemoral pain, which means that it's treatable with things like rehab, and you don't necessarily have to have surgery to address the cartilage. Not always the case, but most commonly. So here again, we saw the patella cartilage, zero sensation, ACL 1 to 2, ACL insertion 3 to 4. This is on a scale of 0 to 4. And then meniscus and articular cartilage 1 to 2. But the most important thing was that he said that touching the anterior synovium and the fat pad, which is directly under the kneecap, produced severe pain that elicited involuntary verbal exclamations from the subject and nearly resulted in the cessation of the study. So this answers our question of it's not the patella, but it's the synovium and the lining around it that can become irritated, and it can become really painful. So summarizing this, the grinding and the chondral injury is not the source of pain. It's typically an overuse and irritation or some sort of trauma that causes pain that leads to quadriceps inhibition, which leads to joint overload, which leads to more pain, and it becomes this vicious cycle. So that's why the treatment for this has to incorporate all of these factors and address all of these factors. This means addressing the inflammation to break that pain cycle, anti-inflammatories, ice, a little bit of activity modification. This doesn't mean do nothing, but maybe, limit the squats, limit the lunges initially until we can get rid of that inflammation. Then quadriceps strengthening. So there's more than one way to strengthen the quadriceps. You don't have to necessarily do lunges or knee extensions in order to do that. And the goal here is to strengthen the quad without overloading the joint, because every time you irritate the joint, you're going to shut off your quad. And so this is why the rehab is really important. Quadriceps strengthening will offload the patellofemoral joint, incorporating hamstring stretching and anything, weakness in the hip, all of these things can contribute. Addressing malalignment. So obviously we can't do, non-operative osteotomy, but things like patellar taping, arch support for the pes planus, and VMO strengthening, which is not alignment, but again, a dynamic process in terms of the overall alignment of the extensor mechanism. These are all ways that we can address this. And lastly, patient education and getting them to maintain this and understand that this is something that they're going to have to continue, not just do twice a week for 6 weeks and then they're cured, is really important. So in summary, patellofemoral disorders are spectrum, as we talked about today, between pain, which is primarily non-operative, and instability, which often becomes operative if it's recurrent, and it's multifactorial in nature, and it's not all the same thing, okay? And this is what makes this field very confusing. The physical exam is critical to detect and confirm instability, which is very different from pain. And when we do detect this, we need to individualize the treatment and address the specific deficiency that the patient has. For treatment, first-time patellar dislocations don't often need surgery unless they have a chondral fracture or a loose body where something greater than a centimeter is floating around the knee. Recurrent instability typically needs to be addressed. Not good to keep letting that go. And history and physical examination are critical. The MRI is not always going to show you instability. Instability is a dynamic process that needs to be diagnosed on physical examination. And so you have to get really good at that part. With the surgical treatments, MPFL or MPFC reconstruction has become the mainstay of treatment, but there are complications associated with this in terms of the surgical technique. We also know that that's not the answer for everything, and you have to address the malalignment and potentially the trochlear anatomy at the same time. Otherwise, you can increase your risk of failure. However, you only want to do those procedures when the patient really needs it because of the risk of complications with that as well. And lastly, medial instability, very uncommon, but it's important not to miss. And we don't want to see lateral releases as an isolated treatment for this because that can be problematic. So the treatment goals are to identify and address the contributing factors, to differentiate between stability and instability, to give the patient pain control and reduce the inflammation, and finally to provide patient and provider education going forward. Thanks very much.
All right, thank you. And we have quite a few questions here. I'm just going to start from the top. So Louis asks, what specific exercise do you think is the best for VMO strengthening and isolation?
Yeah, there's a lot of discussion about this, and can you actually isolate the VMO? And some people will talk about, external rotation at the hip in order to isolate the VMO. I think it's more of a qualitative thing, and strengthening all of the quad will give you more VMO strength. And in addition to, how many pounds you can do, it's how are you engaging? How are you getting good control of the extensor mechanism, as well as, the hip, and looking at hip drop and things like that. So I think it's more of a combination of those things.
All right. Robert asks, can an athlete return to competition after a quick, I'm assuming this is a patellar dislocation reduction, if other testing is negative, and then refer for imaging the following day?
So, as I showed with the MRI, you can have a chondral fracture or something like that that would either need to be repaired or addressed. So, it would be one thing if somebody is, this happens kind of occasionally and they've had it before and there's not a lot of swelling. Even that kind of, bothers me a little bit. And if this is a first-time dislocation, I think there's just no way to tell if they have some sort of chondral fracture or a chondral or a loose body that needs to be addressed. And so I would generally say that it's more important to get that figured out before returning them to play.
All right. And Russ asks, how do you get the patient to relax their quads so you can test for glide and tilt? As soon as I touch them, they contract their quads.
Yeah, that is a tough one. Sometimes just leaving your hand on the patella without actually pushing on them for a few seconds to get them to relax is honestly the best way. Starting with other parts of the exam of the knee that are less painful is another way that I do that. But most patients are able to relax at some point with a combination of those kind of techniques.
Victoria asks, for pes planus, are there specific types of over-the-counter orthotics that you often go to?
Yeah, so I'm not associated with any company, but I have found Superfeet to be something that have been helpful. They, you know, they can have the ones that provide medial arch support, and they come in different sorts of gradations in terms of firm to, you know, less firm. I think also, you know, at the running shoe stores, they will typically be able to fit them. And so it's not just about, hey, slap on an orthotic, but have somebody watch you walk and run and see what needs correction. Because again, it's not just, you know, what do your feet look like, but what is the dynamic process when you're, you know, taking these steps. So I like that, you know, a running shoe store will often be able to help fit those as well.
Do you tend to approach the pre-growth plate closure patients differently than post-growth plates once their physes have closed?
For surgical treatment, is that what the question is?
Or for the orthotics?
Oh, for the orthotics. That's interesting. You know, I would say that this is for pain or for instability?
For
I would
pain, for
for pain.
patellofemoral pain.
For patellofemoral pain. So generally, with the younger the patients are, the more likely they are to respond to rehab, with the reason being that they typically tend to fall behind in their strength because they're actively growing. And so I'm pretty slow to throw on things like taping or orthotics, especially until you've maxed out everything else that you can correct dynamically with PT.
All right. Well, wonderful. I'll give everybody another minute or two if they want to put any other questions. We had over 100 people here, so
Wow.
certainly very well attended and very lots of keen interest in the topic.
Great.
All right. Well, very good. Well, thank you everyone for coming. Thank you for presenting. This was fabulous. Certainly lots of keen interest, and who knows, maybe we'll have you come back again for a women's and sports medicine topic.
Sure.
That would certainly be fabulous. All right. And I hope everyone has a great night.
Thank you so much for having me.